We have a question over here.
Given that the patient here has the 1 in 1 million cells, would the recommended maintenance be 4 drugs or 2 drugs? Because I think it was the first speaker that was talking about the 4-drug therapy for maintenance. He has the 414, the T414 without the Q.
So no, this is loud. The treatment for newly diagnosed myeloma is induction, followed by consolidation, followed by maintenance. Maintenance, if you go through transplantation, for instance, maintenance is with 1 or 2 drugs, not 4 drugs necessarily, okay? Patients with a 414 translocation do benefit from 2 drugs, especially that proteasome inhibitor, if possible, such as Velcade, right, or bortezomib, or carfilzomib, or ixazomib. And that is because specifically for translocation layer 414, that addition of the proteasome inhibitor seems to negate some of the bad outcomes from that high-risk mutation. And those mutations would technically continue, those 2 drugs for maintenance would continue technically until disease progression or intolerable side effects. That being said, quality of life and toleration do matter, right? Because if the patient is having horrendous peripheral neuropathy from Velcade, we should not be pushing the envelope too far, right? We have to make sure that it's safe. Now with the new data from Auriga and Cassiopeia also, it seems that daratumumab has a significant role as well for all comers in terms of maintenance with 2 drugs rather than just 1. The other side of the spectrum would be for those patients that have high-risk disease and they're not transplant eligible, right? Transplant eligible, as we discussed, it would be either IMROS or probably Cepheus in the future, or Maya, right? And those therapies continue to disease progression or intolerable side effects with 2 drugs as well, the Velcade being dropped after 6 months, technically speaking.
So just to add on to that, exactly as we said and as we discussed in the previous session, your current maintenance plan of 2 drugs is appropriate, but the confusion I can kind of see where it arises from. Some clinical trials are designed in such a way that there's induction, 4 drugs, transplant, and then some trials also give a consolidation 4 drugs, and sometimes that's interpreted as, should my patient get 4 drugs? And when patients read it, they often come to us asking, why are you not giving me 4 drugs after transplant? But, that's the way the trial was designed. That's not how we normally treat. So, yeah.
And also that MRD negativity that we already discussed as well is very important, right? Getting to that MRD negativity status is crucial because it's going to predict a longer response.
Hello, so my name is Anna, and I'd like to thank all the presenters for the amazing presentations we had here today. And I'd like to ask about, for Dr. Hansen, you presented some data about the Majestic 5 study, and with this use of the teclistamab in newly diagnosed myeloma patients, but I didn't see if they compared with the standard treatment, and if is an ongoing study, and how about that? What do you think about that?
Yeah, that's a great question. I think the bispecifics, there are multiple ongoing clinical trials, like in the frontline setting. That is an early study just to see, how well things would look from like a safety perspective, from, the infections, as well as efficacy. I think really you're going to get to the phase 3 studies once we treat enough patients, right, that it's safe and it works well. Once that is established, then we'll go on to phase 3 studies and compare it to kind of standard of care options like the DARA, VRD, et cetera. But there are many bispecific studies in combinations in the frontline settings that look quite good, but a lot of them are kind of the early phase studies, but some are upcoming as well.
I don't know if any of you have a crystal ball. But if you do, when do you see CAR-T as being frontline therapy where you don't have any concerns about insurance and If that's what the person who has multiple myeloma chooses as frontline therapy. Do you see that coming in the near future?
Well, the main study that is being run right now is still ongoing, right? So accruals are going to potentially be completed in this coming summer. And from that time, it's probably going to take a few years for us to find out, right? If you think about it, like the therapy that we provide right now as a standard of care to patients, meaning the 4 drops, transplant, and maintenance, is pretty good, right? It puts patient in remission like a little bit over around the 90%, right? So trying to beat that is very difficult, right? So and to see a difference, especially in terms of survival or even progression-free survival, right, is going to take some time, right? Probably the MRD sort of like analysis is going to give us a hint, but probably it's going to be the follow-up that is going to tell us when that's ready, right? Now, once that shows, let's say, that the CAR-T is beneficial compared to the standard of care that we have right now, then yes, it's going to be approved probably by the FDA, and then it's going to need to be, work up in terms of like what is going to be the cost, right? The cost is very expensive, right? So insurances also, they have their own agreements with different institutions depending where patient needs to go. So that's something that will need to continue to be worked out, right? There is many things like politicians, believe it or not, can lobby, to bring the prices down, to have more access, right? And I think the next step also will be to bring this type of therapy closer to the patients, right? Because there are patients who need to travel 6-5 hours, to get to the closest center that can provide this type of therapy, right? So trying to move this type of therapy also closer to the community will be also the next step.
Is there any data citing what percentage of patients are not MRD after transplant?
Negative.
MRD negative, sorry.
There are many studies that have transplant built into the study design. A lot of them are triplets followed by transplant, and the newer studies are quadruplets followed by transplant and then maintenance. But on an average, and I alluded to it earlier during the MRD discussion as well, on an average, patients who go through a quadruplet induction and then gets autologous stem cell transplant upfront after, they have an MRD negativity rate of more than 50 to 60%. So on the other side, the flip side, there's like a 40% of patients who don't achieve that negativity right off the bat. We do see, though, that this may change. MRD tends to be a dynamic status. Once you head into maintenance, be it with 1 drug or 2 drugs, those who entered as MRD positive may turn negative and sustain that, and vice versa too. But those are some like a condensed, additive percentage if you want. But again, they vary from studies to studies, but this is like an average percentage.
Hello. So I have a question regarding CAR T cell. If you've had a stem cell harvest and you have that in storage, and the time comes that you're looking into CAR T cell therapy, can the CAR T cell be extracted from that stem cell collection and worked, or do you need current CAR T cells to be genetically modified? They can't use what's in storage that would be less exhausted. In other words, my question regarding the cell itself.
Yeah, that's a great question, and I'll start first and let my colleagues weigh in as well. Currently, the answer is no. Stem cells are different types of cell. They're kind of like very powerful that develop into, white blood cells, red blood cells, platelets. T cells are a subset of a white blood cells, which is what is used to make the CAR T cells. And generally speaking, currently, like insurers or anybody else is not allowing us to use those older cells anyway. But as it stands, we have to collect the T cells before we manufacture and not use stem cells. With that being said, there are studies ongoing where if the T cells are less exhausted, perhaps, things do look better. And there's a recent study published by one of our colleagues showing this, and by Dr. Garfel at University of Pennsylvania. But I'll let my colleague, Dr. Castaneda, weigh in on this a little bit more as well.
Yeah, thank you, Doris. Yes, what Dr. Hansen is saying is right. Right now, we don't use, even though there are T cells in the graph that has been collected, right? There are T cells there. And where, for example, Dr. Freeman has shown here a Moffic, is like you could isolate those T cells from the graph that is frozen, right? Like recover those T cells and manufacture CAR T cells. But this is being done on a small scale, right? They are only producing some few thousands CAR T cells, and then they are assessing what is the killing power of those CAR T cells and comparing to the same patient, but years later, right? And collecting cells at the time, right? Of course, the killing efficacy of those CAR T cells is going to be better when you use the younger, store cells that were exposed to less therapy. But the question will be, are the T cells that are in the graph enough, right, to manufacture the dose of CAR T cells that you need, right? That's the first obstacle, right? That's the first hurdle. So because, when you collect T cells to send for manufacturing for CAR T cell product, there are billions of T cells that are collected, right? Your blood volumes goes through the machine multiple times. We process up to 12 liters of your blood to select those cells before sending to the manufacturing facility, right? So that will be probably, with the available technology, the limitation, that we won't have enough T cells in the graph that is already stored to manufacture the adequate cell dose, right? But in the future, technology may continue to develop, and they may be able to expand those cells to the scale that is okay for treatment, right? And then that could be used, right? But I think we're still years away from that. But yeah, it's an interesting concept that has been proven, but only on let's say like in vitro sort of a scale, right? Not in a human model.
I'll add one more thing. Obviously, it's very important to try and develop CAR T cells out of non-exhausted healthy T cells. And so we are also in the process of developing what are called allogeneic T cells. These are T cells from healthy donors that we genetically modify to not be killed by the patient's immune system, and also to be effective at killing myeloma cells. So this is an ongoing area of research. What this would mean is that these CAR T cells could be off the shelf, like any of the other drugs that we use, and could be used immediately without significant delay and reduce costs, perhaps. So it's an active area of research right now.
I have a question regarding the stem cell transplant. So and I know I kind of asked before, but from harvest to transplant, how long are you immunocompromised, like from start to finish?
You're talking about how long are you immunocompromised after the harvest to the transplant?
Yes.
Well, the immunocompromise actually occurs after the transplant. So we say most patients are immunocompromised for at least the first year after the transplant. We recommend vaccination of many of the childhood vaccines towards the end of that first year when their immune system is starting to become immunocompetent competent again. So that first year is the highest risk of infection.
Leaving the house. Oh, sorry. So no leaving the house. I mean, no.
Not that strict.
Okay.
No, we're not that strict. Maybe when you're neutropenic, when your neutrophil count has not fully recovered, that's when you're even higher risk for infection. But if you were asking, when does your immune system go back to normal, I would say at least 12 months. But for the first month for sure, while you're waiting for your stem cells to recover, I would say that's when you need the most protection, staying indoors and avoiding crowds.
when is the optimal time to measure the MRD after transplant?
So that's a great question. And just to piggyback, on the previous question as well. So transplant, like CAR T, is kind of a process and it takes time, right? Generally speaking, and I can speak for our center here, between the time of collecting your stem cells to the time of actually receiving them at our center, it varies somewhere between like a week to 2 weeks. And I agree with my colleague here that, you're not going to be any more immune compromised after the collection that you were before it. It's just going to be that, month after to make sure your blood counts have recovered, to where, we might be a little bit more careful. Once you get to go home after that 1 month, generally, we do raise a lot of restrictions, whether it be eating certain type of foods, washing your clothes separately, doing all of those different things. Most of our patients, generally, if they're not retired, they'll go back to work at about 3 months. At Moffitt, we do start vaccinations at 3 months following the transplant. And we generally, our schedule might vary a little bit, but we do 3 months, 6 months, 12 months, 18 months, and we end at 2 years. So it's kind of like a 2-year vaccination process. In terms of MRD testing post-transplant, generally speaking, our reassessment occurs at 3 months following transplant, where we will do myeloma labs, we will do a PET scan, we will also do a bone marrow biopsy. At our center, we do clonoSEQ testing, which is kind of the most sensitive way to detect MRD. But at 3 months is when we assess that first level. And then generally, ideally, you would do yearly after that, but sometimes we might not, depending on what treatment you're on, what the plan is, and so forth.
Is there a time limit, or not a time limit, but a time where if you're going to be MRD negative, that you're more than likely going to be negative at a year or 18 months?
We're still discovering that. As Dr. Hansen said, the earliest time point we check is 100 days after transplant. And as per the FDA ODAC meeting that happened a year ago, they do mandate that between 9 and 12 months from the transplant, you should have at least one MRD assessment. So if you ask about an optimal time, that would be the correct answer. Between 9 and 12, at least that's the sustained sort of MRD assessment that needs to happen. But almost all of our centers do it at 3 months and then 1 year post-transplant and then a yearly restaging as well. We do not yet know what sustained MRD negativity means. We have a lot of clinical trials that are asking the exact same question. If someone is sustained MRD negative for 2 years, does that mean that will they never become MRD positive? Or is that number 3 years or 5 years or more? We are actively looking into that. And, the Auriga trial, there are many other maintenance cessation trials that are answering the exact same question. If you're MRD negative, can we de-escalate treatment? If you're MRD positive, do you de-escalate or do you escalate treatment? So all of those answers are coming, but we don't have them just yet.
I'm going to ask a question to my colleagues. Since we're talking about maintenance and we're talking about MRD negativity, what are your thoughts about, let's say, a standard risk patient that might not want to be on maintenance, terribly for a long time? What is your practice like? How do you use MRD testing to make decisions? You can start, I guess.
Sure. Yeah, so we have to first acknowledge that we do not yet have all of the evidence to be able to make a decision based off all the data. It's still ongoing. So at this point in time, I believe it's a discussion between you and your physician to decide what's best for you. For some patients, life is miserable on maintenance therapy, and for others, it has no impact. And so you really need to take that into consideration when deciding what's most appropriate for you. But for a patient who's sustained MRD negative, I think it's very reasonable to consider a trial off therapy. We can always restart it. And it's not like once the disease comes back, there's nothing more we can do. So you could certainly take a break off therapy and reassess regularly to see if the disease is coming back. But for patients who are doing really well, I don't like to rock the boat. If they're happy, I'm happy, let's continue on the treatment.
Yeah, I agree completely. I think it's a very individualized decision, right? But we have to acknowledge that the data is not mature enough for us to recommend to either stop or continuing your maintenance based purely on the MRD status. Just like my colleague just said, if it ain't broken, don't fix it, right? If you're tolerating your Revlimid well and you're doing okay, it's hard to change a winning horse. But for those patients that are having a tough time with the medication, that are having financial toxicities, or simply want to have a treatment-free interval, it's hard to make an argument and tell them, no, you should continue undeniably if you're MRD negative, if you have sustained MRD negativity over several years. So it's a personal choice, right? And we always have to have that deep conversation with our providers to see what the best choice for you is, right? It's not a one size fits all. On the other hand, if you're MRD positive, then that gives us ammunition to tell you, I'm not truly feeling very comfortable stopping your maintenance right now. As a matter of fact, how about if you're on Rev only, how about we add DARA to try to deepen that response or recapture, at least temporarily, and then we back off also. It's kind of a fluid and dynamic conversation, right? But like we've emphasized, I think the standard of care now is to pursue that MRD negativity and make sure that you possibly get the longest possible run without being at the expense of your quality of life, right? Because that's extremely, extremely important. What's the point of having a pulse if you're miserable while on it, right?
I guess I'll ask one more question and then Jenny. Oh, no, you go ahead. And then we'll ask.
I wanted to add, or maybe redefine MRD negativity, minimal residual disease. I actually have been diagnosed back in 2013. I heard about RMD in 2014. I'm thinking, oh, this is a different test. Maybe I don't get it, you know? And I'm thinking I'm at an aha moment. My original response, it was a stringent complete response. Then I've had some, good, very good. I'm on very good response right now, although I think I could be complete response because I've had no M spike for almost 2 years. But I guess my question is that I've heard this MRD all this time, and that's just, if I'm not mistaken, that is just a way to actually assess my response, correct? Am I right with that? Okay. So, and you have to do it through a bone marrow biopsy. So my first question is, can you, because I've never seen MRD on there, but should I take those times that I've had the biopsy, and would that be kind of like my trend over time in my journey of how I've done over time? And the second question would be maybe just a little bit of discussion on the newer approach with mass spectrometry.
Sure. So first of all, I'm very glad that you heard MRD all the way 10 years back, which is excellent because, yep. Right. Right. So just to simplify things, right, MRD or measurable or minimal residual disease is just simply referring to how much is, if there is disease left at the end of treatment, how much is it and how do we quantify it? Now, 10 years ago, when we talk about blood-based testing, the level of sensitivity is 10 to the power of -4. -4, -5. -4 was where we started at, your M spikes and immunofixation, etc. Fast forward, we started taking bone marrow samples, running them through flow cytometry, and flow cytometry gives us standard across the board in all institutions. You get 10 to the power of -5, and in some institutions, you also get 10 to the power of -6. So that's how deep flow cytometry can go. In the last couple of years, though, we've had a new test that has been FDA approved, which is clonoSEQ by the company Adaptive. Some of you may have had it. That has an even deeper sensitivity of 10 to the power of -6. If you imagine it like an iceberg where you're looking at the submerged portion of the iceberg, the top part of the iceberg is your manifested myeloma, the submerged portion is your invisible part of the myeloma. You know it's there, but you can only see it as far as down as the diver can go. And right now, we are at a diving depth of 10 to the power of -7, but -7 is not really commercialized or FDA approved yet. Now, mass spectrometry using MALDI-TOF technology that's coming to the fore. There are like CyTOF technology, MALDI-TOF technology, and there is also a clonoprotein, like there is other proteins that are now coming to the mix that can give us even purportedly 10 to the power of -8. They're all in trials. They've not come to the fore yet, but that's going to be the future in the next 5 years. That's how deep we can go. So that's about that. There's one other aspect of MRD that I didn't touch upon because that's still not really experimental. It's coming along the way. It's probably bypassing bone marrow and instead measuring residual disease in the blood. There's a new term that people are calling. It's called peripheral residual disease, or PRD. Some of our international colleagues are actively working on it. And let's say you are negative in the bone marrow, but positive in the blood, or vice versa. There are treatment decisions, or we can even make decisions. If you're negative in the blood, do we even need to do a bone marrow? And you can bypass a bone marrow. But if you're positive in the blood, then you may need to get a bone marrow. So there are studies that are looking into that, and that may be the future of how we even decide to get a bone marrow. And again, in the future, we may just do that port. We saw Dr. Coffey present, maybe a combination of blood-based testing, and if you need it, just go in that one spot and do it, less pain for patients.
Just as a comment, we're a patient project. And Julie's last follow-up, they did just at the flow cytometry, the mass spec, and they report it as a regular clinical finding, but at the bottom it says it's not FDA approved. But so the Mayo Clinic's already incorporating that in their results that they give back to routine patients.
Yeah, no, you're right. So we've been, we work with a lot of colleagues from across the country, Mayo Clinic being part of that group. You're right. At Mayo Clinic, they do mass spectrometry, but I don't know that it's available elsewhere to be done, nor that it is, approved. But certainly it is a way to be able to identify MRD at a deeper level.
They haven't told us that this is valid. They haven't proclaimed this is valid, but they're sharing it with the patients, which I thought was interesting.
Yeah, it looks good, right, if you're able to do it.
Mayo has done a lot of validation within themselves, and that's why they feel confident to share it. But to reach the threshold of FDA validation, there needs to be bigger studies, broader multi-institutional studies. I think they'll get there. There are many companies that are coming to all of our institutions and trying to incorporate in clinical trials. But as of now, that's the reason outside of, and we even send some of our patients there to get, I think Dana-Farber does it, and Mayo Clinic have mass spec. And our institution at Memorial Sloan Kettering, we also have mass spec. Again, we don't share the report with the patient. We just inform them because, again, we haven't validated it as well as Mayo has. But we're getting there. And that's just, the analogy I mentioned. That's how deep the diver goes. That's 10 to the power of -7.
I think this MRD thing is fascinating, right? There is no one single way of assessing MRD, right? So they have mentioned flow cytometry. They have mentioned like a DNA-based testing, like the adaptive, the clonoSEQ testing, right? There is mass spectrometry, but there is also circulating free DNA, and there is also like circulating, in this case, plasma cells, right? That could tell you that. Because remember, the clonoSEQ or the flow cytometry testing only tells you there is residual disease potentially in your marrow, right? But as people continue to go on their journey with myeloma, you may not have relapse of disease in the marrow, right? You may just relapse with a bone lesion. You may just relapse with what we call extramedullary disease, right? Like a myeloma lesion in an organ or in the skin or in the muscle or somewhere else, right? So those things, MRD will miss it, especially the two ways that we do it with flow and with clonoSEQ, right? So that's why the other things that your doctor do, right? They do your blood work and they do a PET scan or some other imaging every so often, right? Just to see whether or not this MRD negative still means, there is no evidence of disease anywhere, right? So it's not that straightforward, right? But and it gets confusing sometimes. And I think that probably at some point will be like a better test, like the circulating DNA, that will tell you right? Whether or not there is disease still anywhere in your system, right? Not necessarily will tell you from where, but will tell you that it's still there, right?
Yeah, I have a question, a quick question. First, a note, I admire you all. You have the most difficult profession that I believe is in the world. My background is automated control and electrical engineering, automated management system. I bow my head because you deal with the most complex system in the universe, the human body, and you don't have the 100% documentation that we deal with in engineering. So now one question, is it possible that there could be MRD detection using some kind of MRI with fluorescent contrast, whole body MRI with some kind of, it's outside my field, but it's fluorescent contrast with different biomarkers, whatever, and then you detect all that instead of one incision in one area, which is the bone marrow, is in other places too, no? So that's pretty much it. Thank you.
I can comment on a clinical trial that we have at the University of Miami addressing your question. First, I want to say thank you for saying the nice things about our professions. I love what I do because I see so many amazing, great outcomes from the treatments that we have. So my job is actually not as hard as maybe you think it is. So much success going on in myeloma today. So what you're talking about is, can we have a scan, correct me if I'm wrong, but can we have a scan that can directly detect myeloma? The basic scan is a PET CT scan, which detects rapidly dividing cells. Cells that are uptaking sugar are usually those that are rapidly dividing, and we can see those on a PET scan. Well, at our institution, we are investigating a new technology that looks for CD38 positive cells on the scan. So it uses an antibody that will emit an indicator of some type that can be detected on a PET scan so that we can see if the cells that are rapidly dividing are plasma cells or not. So that technology is evolving, and it would help us more accurately identify what's called extramedullary disease that goes outside of the bone marrow, which when that happens can sometimes be really challenging to treat. So I think it's important to think of MRD not just as a one test, but probably a multimodal test, one that incorporates imaging, blood, bone marrow, and perhaps if all of those criteria are negative, then we can truly say the patient's MRD negative.
So I have a question about when you are diagnosed with multiple myeloma. A lot of people find out because they have a broken bone. Some have no lesions at all, which is his case. And I want to know the condition of your bones throughout the disease process. I think I should already know the answer to this. Would a bone density be indicated? Does the PET scan take the place of that? Should there be medication that they are on for precaution for, is it osteopenia, osteoporosis, breakage? So that, how careful. I don't want him lifting anything. I'm a little too over controlling. I'm like, no, don't do that. Please don't do this. So I just want to relax about it.
So bone health is important in multiple myeloma because, as you know, the bones are typically targeted by myeloma. We can get holes in the bones. It can weaken the bones. It can result in fracture. We can do something about it, though. There are medications that build bone, keep it stronger, and prevent some of the complications that come with that. So if you're not on bone strengthening medication, such as Zometa as an example, or Xgeva, these are medications that that is recommended for all patients with myeloma. Also, vitamin D should be checked and replaced if it's low, because that's also important for bone health. And then I do DEXA scans occasionally in patients just to see what their bone density is, especially if I'm considering stopping the bone strengthening drug. I want to make sure their bone health is adequate before I do that. So there is a role for DEXA scans in myeloma to check bone health. And finally, I'll mention, since we're talking about it, if you are going to receive bone strengthening drugs, you should have a dental evaluation beforehand, as these medications can lead to what's called osteonecrosis of the jaw, a very undesirable side effect. It's usually in patients who have dental issues, and so we want to screen for those first, make sure you don't have any. If not, then you can proceed with the therapy.
Should there be a preliminary DEXA prior to starting the medication, or should it just be?
I recommend it regardless of the results of the DEXA scan. So I don't think it's necessary, but let's say you've been on it for 2 years, you're wanting to go off. Maybe at that point in time, it might be reasonable to consider your bone density. There's no strong guidelines on that. It's my personal practice.
Going back to CAR T, I'm wondering, now that it's more available, will people be able to get more than one CAR T? And when would that be in the line of things?
I think it's happening right now, right? So patients are getting what is commercially approved right now. And then our patients who are progressing after that first CAR T, we're trying to enroll them into the newer CAR Ts with different targets, right? We're enrolling them into the GPRC5D trials. We're enrolling into the dual targeting trials to see what is going to be the impact, right? All of these trials are going to have a cohort of patients that they are going to call previous BCMA exposed, right? So when the data from those studies come out, we're going to know whether or not it makes sense to sequence in that fashion, right? So, but yeah, we are kind of like doing it, but I think it's just a matter of like having the data on hand in the future from those studies. Yeah.
Okay, I want to ask one last question. What do you wish patients would ask you in the clinic?
Depending on the answer, right? I guess my friends might say different, but you know, when I talk to my patient, I'm more of like a half full kind of person. Other things I might be glasses half empty, I don't know. But like, I mean, we're here, we're going on this journey together. I get very excited about what's coming down the pipeline, you know, what are additional things that we can do beyond, you know, what I can do now. So I think for me, being able to talk with you all about, okay, where are we now? What can we do? And how can the future look? And talking through like what's exciting. To me, that gets me very excited. And yes, this might be an incurable disease, but we're getting there. There's a lot of excitement. There might be a functional cure. Hold on until the next event. We'll talk more. To me, is talking about the future and what else we can do. It makes, you know, I'm really excited about that.
I think maybe potentially, you know, quality of life, right? Because we are all focusing on the therapy, how efficacious the therapy is, how, you know, the side effects and those things. But think about it, right? Like you are doing therapy because first off, you want to improve the symptoms from the disease, right? That equals improving your quality of life, right? And that will be most of the time, believe it or not, even though you don't say it, right? That's what you're thinking, right? What is going to keep me here longer, feeling better, right? So probably, you know, like strategies to improve my quality of life, you know, those kind of things, right? Is a real role for, I don't know, like exercise, rehab, right? Different type of diet, right? Because you could hear things like, oh, don't eat sugar because, you know, that way you are going to kill the cancer cells and those kind of things, right? So those could potentially be things that, you know, like also we in general, right? Because those are things that we know normally talk a lot, will potentially benefit on hearing more from you guys.
I would say that the best question to ask to any of us is whatever question you have in mind. Because ultimately, we're not here to make decisions for you, right? This is your journey. We're just a passenger on this ride, and we're cruising this with you guys. It's really hard for you to make a decision without our information. But like you mentioned earlier, every single visit that you go to your doctor, you might remember 10% of it. So repetition is key, right? Do not leave the appointment with questions in your mind, especially when you're seeing one of us. Typically with the community doctors, it's more difficult, right? Because it's shorter visits, they have more patients, yada, yada, yada. But for us, we're here to support you with any concerns or questions you have. And take advantage of these platforms because unfortunately, Google is very powerful. Google sucks. And you have to be using the right sources of information, right? And so just don't be shy. There's no stupid question. Stupidity comes from not asking it, right? So just go for it.
I think one of the questions, Jenny, your question was what is a question I wish I was asked? But the question I get asked the most, and it's a question I wish all of you would ask your physician, is what can I do? And that's been touched upon earlier. Like everyone's journey is different. So, what you eat is different. What you take is different. Your supplements are different. Your medical comorbidities are different. Your exercise plan or a new plan to exercise, everything is different. And the one thing we always want to know is how transparent is that? And we can optimize that for you, especially medications, be it cardiovascular, diabetes, supplements. I don't know about Florida, but back in New York, I get a litany. Trust me, I have a patient with 21 supplements, and I had to run the list by my pharmacist, and my pharmacist took away 13 of them. And that's something you may think is harmless, but please run it by our team. Not making this up. We need to know some of them as innocuous as vitamin C can interact with Velcade. So something that you think is very innocuous may have deleterious effects and may not help your treatment journey. So please, and yes, it floods our in baskets with questions about, can I take this, can I not? But we would rather know than not know of what you're taking and what you want to do. So that's not a question I wish patients ask me. They ask me ad nauseum, but it's something you should keep asking. And we've caught many patients from taking, herbs that are good, herbs that are not good, medications that interact. And, I think that's something that you need to run by your medical team.
Perhaps you can ask your doctor if they recommend a second opinion. If you aren't seeing a myeloma specialist, you're seeing a general oncologist who sees breast cancer, prostate, and myeloma, and you're at a difficult point in your treatment and you maybe sense lack of confidence in the next decision, don't hesitate to request a second opinion. If the doctor's offended, that's a red flag. All physicians should be open to getting additional support and opinions from other doctors, even if you're the top in your field.
Yeah, if your doctor gets mad at you because you went for a second opinion, that is definitely the time to get a second opinion. No, seriously, we just know a little bit, right? And I think we complement each other and we can see things in a very different way. So absolutely, second, third opinions are absolutely welcome. No doctor shopping, though. It's not like you're going to go to 10 different institutions to get started.
That is incredible. Dr. Hansen, Dr. Rajiv, Dr. Castaneda, Dr. Grajales, Dr. Coffey, thank you so much for being here today and helping support patients.